I have been doing Activator. Yeah, everybody come up here. Stop being over there. I've been doing Activator as an advanced proficiency rated doc since 2006 or 7 or something like that. And I think that there's no greater tool to use with kids than Activator. My hands are great too, but I think there's no greater tool to really make a change than Activator, because it is a universal technique. Some kids are more responsive, believe it or not, to using an Activator than they are to just using your hands. And to me, the most important thing, especially since like the predominant kiddo that I see in my practice is a kiddo on the spectrum, and especially the minimally speaking kiddos. So to do, not that it's bad or wrong, but to do a more osseous kind of adjustment like this, a lot of kids on the spectrum, especially the more severe ones, like the autism level 3 ones, they have a problem with something called interoception. Interoception is unable to understand the feelings that they're feeling in their body. So if they're like, you and I may say, I think I have to go to the bathroom, right? And we can feel the sensation, right? And we get like the little call from, our body saying it's time to go to the bathroom. And then, but I can say, well, I just started my talk here and I have to wait. So I have to wait, and, but I can manage this, right? And I can say, okay, well, I can predict it's 11 something now, and so by 12 o'clock I'll go to the bathroom. So I can have this inner dialogue, even while I'm talking to you. I can have this inner dialogue and be totally okay with it. But a lot of kids on the spectrum, especially the more significant autism level 3 ones, do not have that same ability. So a lot of them will not know to go to the bathroom until you tell them to go to the bathroom. A lot of them will not know that they're hungry until they start getting like upset, and then you say, here's some food, right? So they have this disconnect. So this sort of adjustment, like this, what do you think that does to them? Yeah, it's overwhelming. It's like putting an atomic explosion into this little area, and I can only tell you from my very early forays with kids on the spectrum in the 1990s, when I did a lot of Gonstead stuff, that it was not a pleasant experience for the child or for me, because they would scream bloody murder. Because like, imagine not being able to understand. This is like, even though I explain, I'm going to do this and this is going to make this kind of noise. Imagine having no frame of reference, and then you hear this explosion in your neck, right? So I am like so blessed to have found Activator, because that tool has given me a way to adjust these kiddos without it being so like scary and daunting for them. Now, to be honest, in the beginning, I will use sustained contact with a lot of my adjustments when I first deal with these kiddos with autism, because I just want to, my whole goal in the beginning is to create a bond of safety, so that they trust me. And usually when they come in, their nerve systems are so dysregulated that to just jump into, even an Activator adjustment, this isn't working, but this is Dr. Kennard's, but even that it doesn't, you and I are like, it's nothing, right? But for them, this is still, like I had a kid yesterday who said, that's so loud. That's so loud. And I adjusted him, I'll show you how to do this in a moment, but I adjusted him with my finger dampening over the atlas, but he says, that's so loud, right? But that's because of the sensitivities that they have, right? So that even though they may not be able to interpret like their inner feelings, but these noises and stuff, they're very attuned to certain noises. So in the beginning, I'll use sustained contact, but then once that my re-exam shows that they are doing better, which is usually after 5 or 10 adjustments when we do our re-exams, then I will introduce the Activator to them. And usually I'm actually using the 2, but this one is not exactly friendly. So, but you all know what it sounds like, so I don't have to, introduce you. But usually I'll go like this and I'll say, hey buddy, and I did this yesterday, first adjustment. I said, hey buddy, I'm going to use this with you today. Is this okay? Look at this. Can you see it? And let him hold it. And he's trying to gnaw it. And no, don't put it in your mouth. Okay. And what it's going to do is it's going to make a noise like this. Is that okay? And I'm looking in their eyes. And I want to see if they go like this, right? Or if they go like this and they push because I've had that happen where, is that okay? And they push, okay, you're not ready for this. That's totally cool, right? Whatever you want. Patient-led adjusting is what I call it. So like if they don't want that kind of adjustment, I don't care. I have all kinds of layers of backups to use. But yesterday I showed, I said, is this okay? Is that okay? Okay, good. Can you go on your belly? Turn your belly. All right, and now I checked, and I was going to show you that like there's 4 basic checks that you can do on a kid who cannot do all the, the hand things. And I adjusted him, he was totally fine with it. But the key was to, first off, get the nervous system prepared, right? So the first 5 or 10 visits, I'm using other adjustments, tonal, sustained contact, etc. And then introducing this to him after a re-exam to show him this is what we're going to do. And then putting it on his hand, putting it on mommy's hand, showing him what it feels like, what it sounds like, and then actually doing the adjustment. So, any questions?
Do you ever have like the toy activators?
Yes. I don't have one here, but yes, I love the toy activators. I have them all over the office. I buy dozens at a time, and so I probably have 12 or 13 just sitting around in various little spots, and the kids are constantly using them, and the kids are constantly adjusting, like either their parents who are getting adjusted or their dolls that they bring in to make sure they're getting adjusted, or other people. We've had we have an open adjusting area, kind of like this, with 4 adjusting, and then the kids will just start adjusting, and they'll just walk around and adjust kids. It's the best thing. So it's very important. Chiro-clickers are, especially for an instrument-based chiropractor, you got to have them, and a lot of them, so that. Because they definitely make it. But I will tell you, that doesn't necessarily calm them down when you actually hold this and click it. You can use a chiro clicker, and that may, even though it's a great thing, it may not be the bridge. Okay. So you just have to really wait for their nervous system to be ready, and they could play with this thing the whole time. But then you do this, and they're like, no, like okay, whenever you're ready. Yeah. Any other questions? That was a good one.
What kind of, like how long, I guess, does it take for you to see improvements, and what would you say are like the main improvements you see with adjusting kids with autism? So
that's a great question. My care plans for kids on the spectrum are a minimum of 6 months. Okay. And minimum of twice a week. That's just how it's going to be. And I tell parents in the beginning, this is not like going to a dentist with a cavity, and they do whatever they do, and then you're done, and okay, I'll see you, in 6 months or whatever. That's not how it works. It is a child with autism, their nervous system is very dysregulated, and not just dysregulated in the sense of emotional behavioral, but literally connective wise. So they don't have the same connections that a neurotypical brain has. They have more connections, like front of left side to front of right side, and vice versa. But the cross connections is what they don't have as many of. And what that creates is a lot of confusion, and what Dr. Malillo, one of my teachers and mentors, calls maturational dysregulation. So the expectation of like someone who comes in with back pain and you adjust them, and I would expect within like 6 visits or so, you're probably going to start even better, but within 6 visits, I would expect them to start having a noticeable improvement. With kids on the spectrum, after 6 visits, I'm probably not going to notice much of anything. Externally, right? Symptom-wise. Internally, this is why we do re-exams very frequently with our kids, because we will see primitive reflexes change. We'll see their eyes tracking and convergence change. We'll see their heart rate variability change. So we'll see them like objectively change, but subjectively from the mom and dad, I don't see any difference. Mm-hmm. And you say, okay, you may not see any difference. Let's let the exam do the talking. Mm-hmm. Right. And then you do their exam, and then you show them, look, this is where he was before, this is where he is now. Isn't that good? That's some big improvements. So we're making headway. His nerve system is regulating. But ultimately, we see a lot of these kiddos, they will become calmer, they'll become more focused, they will be less aggressive to themselves and others, they will do better in school, they're just much more pleasant to be with. Okay. And some of the kids even start to communicate to some degree, where kids who have never communicated whatsoever will either develop a minimal language, or they will. A lot of times we'll teach them how to use a letterboard, and they will start spelling things. And the parents, it's been amazing how many kids who have been told by their school teachers that they can't learn anything, but when their nerve system starts to turn on, then we teach them how to point. And you'd be surprised, like, you think this is an easy thing. That is not an easy thing. I got a kid yesterday who's very severe autism level 3, and the fact that he's doing this with his whole hand and pointing to a letter is amazing. But it's taken several months of work to get him to point with his whole hand to a letter, right? And eventually he'll get this, right? But now he can use that pointing, and now he has an assistive device, and he can point to like food, water, bathroom. You know, he can say thank you. He says hi, Doctor. He says something, hi, Dr. Rubin. Bye, Dr. Rubin. Can I have a lollipop, please? You know, the important things. So it's amazing what possible changes you can see when you're able to help regulate the nerve system, right? So chiropractic isn't like Dr. Rubin, who unfortunately passed away recently. He's the one who taught me to say this thing to our patients. I'm not a back doctor. I'm not a bone doctor. I'm not a spine doctor. I'm a brain and nerve system specialist. But the spine is my entry in. Yep. But it's not my stopping point. Right? But that's a lot of chiropractors' stopping point. I work on the back. No, you don't. Every time you touch the back, you're working on the brain. Right. I don't care what you think, say, or do. You may not believe and like that I say I'm a brain-based chiropractor, but you're a brain-based chiropractor even if you think you're not. Yeah. Because there is no way to not affect the brain by touching or adjusting, with whether you're using an instrument or you're using your hands. Yeah, good question. Any other questions?
What age do you start using the activator? Like 3 days old, 3 weeks old?
Good point. So if I spoke to Dr. Four about this, and he says with the Activator 5, because it's such a precisely tuned machine, you can use it on any age. But he does say, I caution kids 3 months old or younger, because there have been some really wacky things that have happened with some untrained chiropractors using activators who should never have used activators, and have actually caused some mild but some harm to kids, like breaking ribs and stuff. And little kids 3 months old or younger. So he says better ideally to do sustained contact for the first 3 months, unless you're super well trained and know what you're doing. So generally my advice would be 3 months and older is where is a good place to start. And by 3 months, I mean 3 months with a birth at 40 weeks. Right. So in other words, if you were born at 36 weeks premature, and you're 3 months old, you're not really 3 months old. You're really 2 months old, but in your neurological, processing. So 3 months neurologically. So not out of the womb, but 3 months neurologically. But personally, I like using my fingers for the real little ones, and when they start walking is when I start using the activator. That's like my go-to thing is when they're walking, I use the activator. With the exception of some special things where I will adjust kids who are having some iron or EX iliums, maybe toe walking in or out. So I might wait a little bit earlier as they're just learning how to walk if I see a significant toeing in or toeing out, and it's not hip dysplasia, then I will use activator. Yeah, good question. Any other questions?
For the non-spectrum kid, just for a generalized patient, what is your approach for improvements? I guess if someone comes in thinking their kid is wrong or something's wrong, what are the typical things that you're seeing in just a normal baby?
Yeah, so whether it's like yesterday, we had a kiddo who came in who was 4, who was absolutely beautiful. Oh my gosh, she's so gorgeous. Her eyes were so blue. She was such a beautiful little girl. But she's having ear infection, and it's just so common to have this. What's interesting is like you would think that the kids who are neurotypical otherwise, right, wouldn't have any of the like neurological signs that like a kid on the spectrum does, but that's not really true, because it's just the severity of these soft signs that we see. So even though this young lady who clearly, eye contact, social, communicative, etc., clearly not autism, she still had primitive reflexes, she still had eye issues, she still had HRV issues, she still had all these things, just not to the same degree as a child who's autism level 3 on the spectrum.
Yeah.
So what I have started doing because of Melillo's work is I test every kid the same way. And chiropractic is an important part of that evaluation, but I will tell you that's the end of the evaluation. The beginning of the evaluation is brain and nerve system functioning. So every kid, we start with primitive reflexes, eyes, HRV, balance, and then we hit posture and the spinal alignment and that kind of stuff at the end of everything. Because I don't want someone thinking like, well, the only reason you should adjust a kid is because of pain. I want them to say, oh, there's a lot more stuff going on. And what happens is when there's these positive issues, for some kids, this maturational dysregulation will affect them so severely that's in part why they are on the spectrum. But for some kids, it's going to affect their immune system. And some kids, it's going to affect their GI system, right? So you have kids with colic, reflux, constipation, etc. And you have the kids here who have ear infections or asthma, allergies, chronic colds, strep throat all the time, tonsillitis, right? So the same nerve system things that are going on, some of these kids will be affected more behaviorally, but some of them will have more physical symptoms like chronic colds, ear infections, or like GI issues, constipation, etc. But no matter what, what it is the brain and nerve system is malfunctioning, and that's what I want to show our patients. The brain and nerve system is malfunctioning, and we got to fix it. And that's when we do the re-exams, because like it's you tell someone like, okay, so the big problem with your kid is his shoulder is high and his hip is high, and the parent is like, I don't really see that, right? So but if I go like this and I do some tracking with the kid and the eyes are going like doing, doing, doing instead of smooth pursuit the way it's supposed to, they can see that. So I have like authority when I talk about like, this is going on, your kid's brain nerve system got this going on, and that is causing some issues that is now affecting the way their immune system or their GI system or their behavioral, effects or whatever. And then we can remeasure that later on and show the changes. Like to me, there's nothing better than having like proof, right? Numbers. I got the numbers right here, right? I'm not just saying, how do you feel, right? That's nice, but it's not about that, right? It's about how are you functioning? And if you can prove they were functioning like this before, now they're functioning like this, that's a big thing. Good question. Any other questions? All right, cool. So let me show you a couple of quick activated things, and then if you guys have, my favorite thing to do, since we have no dolls here and no activators, is you can use water bottles. Water bottles make a great baby doll. And you can use, instead of using your finger, if you have styluses or pens or pencils or something, you can use that. So I'm going to show you these 4 things, and then you can all break out into pairs and work on water bottles with styluses. Unfortunately, we don't have any activators. So when we're adjusting Atlas, let's say the kid is a year old or older, because that's my preference. So I'm going to do a leg check like this, and I see that Brittany has a left short leg. So I'm going to tap the Atlas, and what do we call that? A pressure test. I'm going to do a pressure test on the Atlas like this, and if that balances the legs, right, then that indicates that we have a left atlas. And by the way, these 4 things I'm going to show you is what Dr. Four showed us in a seminar about 15 years ago. So that's where so I'm not making this up. This is stuff that he said. Just letting you know. It's the real stuff. So then, if that balances the leg on that left side, it means we have a left atlas. So I'm going to put my finger pad on the left atlas, and I'm going to put my activator on my fingernail to dampen the force, like this. Because this might be too much for the baby. So we're going to go like this. Up until the kid is a year old, 100% of the time when you dampen the force, 100% of the time on every single adjustment, you will dampen the force. And the key is to put it on your fingernail and not on your knuckle, because you do it on your knuckle, you're going to wreck your knuckles. I'm telling you because I've seen other chiropractors who told me that, and they've destroyed themselves. So do it on your fingernail, and I've been doing this since 2008, and there's been no negative. So I go like this on a set with 1 ring, or if I had the Activator 4, it would be on a setting 1. I do like using the Activator 2 better for little ones and for kids on the spectrum, because I don't have the preload, because the preload will add a couple of extra newtons into it. So, and I like making it as low force as I can. So I'll use the Activator 2 like this, and with a 1 ring over my fingernail, and then I'll recheck the legs. Okay. Second adjustment, baby is turned over, or child, and because like I said, I do this on the kids on the spectrum too. And now I'm going to check for the sacral listing. If it's a baby, you could do like a Logan kind of a glute crease check. But I really like the check that Dr. Webster showed us a long time ago before he passed away, where I'm going to do a motion palpation next to S2. So I'm going to push like this and push like this. And if the sacrum has gone anterior, what do you think you're going to feel in comparison? Well, the posterior side will be hard, right? Because it goes like this. The posterior side will be hard. The anterior side will be soft and smushy, right? So you can go like this, and because you're not going to do a 90-degree check with a little kid. It's not going to work. So you do go like this, and then so the soft side will be the anterior side, and the harder side or firmer side will be the posterior side. So if you were doing an anterior adjustment, especially on a kid with like constipation or colic or something, put my finger on the sacrotuberous ligament, and then just like a regular, adjustment on the sacrotuberous ligament, you're going to go PSL like this on the sacrotuberous ligament, and then repalpate. If you preferred, or on an older kid who isn't constipated, you can do the posterior sacrum, but you're just going A, essentially, on the posterior sacrum, once again, over your fingernail if it's a little kid, like this. Then there's the PI and AS iliums. So with little babies and with kids on the spectrum, good luck doing a Deerfield leg check. They will literally go like this with their legs, so you lift them up like this. You're like, come on, relax your knees, and they won't do it. And babies will just fight you. So instead of doing a Deerfield leg check, we're just going to use the sweep, which I know that was written here, but we're just going to use the sweeping concept. So if this was an AS ilium, let's say she's got a shorter right PD, you're going to go from above the PSS to below it like this. If that balances the legs, then we have an AS ilium on the left-hand side, or the OPD side. Dr. Force said with a smaller child, or if you're first starting out with a kiddo on the spectrum, and you don't want to do too much at once, instead of doing all 3 spots, you're just going to do the ischial tube. And you're going to do it AI. So anterior, inferior, like this. And then recheck. Now, if that didn't, your sweeping like this didn't show anything, then you sweep up like this from below the PSS to above it like this. Or you can do a sacrotuberous ligament, either one, but I like doing this with kids because diapers will get in the way. It's like hard to get to that sacrotuberous ligament. So I think it's easy to just go below the PSS to above it. If that balances the legs, now we have a PI ilium on this side. But once again, Dr. Force said, with a little kid or kid on the spectrum when you're first starting with them, instead of doing all 3 spots like this, you're just going to do the iliac fossa with an AS line of drive. And then recheck. And this is very much the Webster protocol of top and bottom, because most kids, Webster used to say, you take care of 90% of the kids' problems today if you adjusted essentially atlas and pelvis. That's you need it. Because most kids are stuck in what? In terms of like neurological stuff? Sympathetics, right? Good. So if you're stuck in sympathetics, then you don't want to adjust the sympathetics in the beginning. In your first early adjustments, you just want to hit the parasympathetics to calm that nervous system down. Because constipation is sympathetic. Colic reflux, sympathetic. Asthma, allergies, sympathetic. Ear infections, sympathetic. A lot of the kids on the spectrum who are like this, or hitting themselves or whatever, they're all stuck in sympathetics. ADHD, the kids are running around, can't sit still, sympathetics. Most of the things you're going to see in these kids are stuck in sympathetics. So in the beginning, Webster used to say, don't adjust everything you find, which is not what you do in clinic, so don't listen to that for clinic, but because you have to learn, right? But in the real world, you only adjust in the beginning what has to be adjusted. B.J. Palmer called it the majors. And the majors, according to Webster, were top and bottom. All right? Good questions. Any other questions? All right, great. So let's go to the tables, pair up if you can. Get your water bottles or other sort of things, and let's practice.